and we will start in maybe 1 more minute, 1 or 2 more minutes. The other session had run a bit long, so yeah, but we are about to start. So feel free to come close, you know, and so that when you ask the questions, and if you know, you have questions and looks of puzzlement, at least our presenters can be able to see them. Yeah.
Oh, I think it's working. It's working. Yeah, I think it's working.
So yeah, again, good morning, everyone. I think we are ready to start. Our presenters are here, and we have you as you know, our honored audience. So yes, I think we can kick off this session. So my name is Patricia Odero. I'm going to be your moderator for this session. I am a deputy director on the family planning team at the Gates Foundation, and you know, will be calling on each of the presenters to tell us a bit of themselves after I give a brief introduction. And so welcome to our session today. The focus of our session is on self-administered methods of contraception. So the WHO has defined self-care as the process of taking care of oneself with behaviors that promote health and active management of illness when it occurs. So and I think the WHO says that self-care is with or without the support of a provider. And so within the family planning space, as we are thinking about expanding access and expanding method choice, self-injection and self-managed methods as a broad category are a growing area of interest. And especially, you know, how do you roll out self-injection? And so our presenters come from 4 different contexts, and we'll be sharing evidence from multiple countries. And so without further ado, whom I will introduce in the order of presentation, but just wanted to maybe just have them, you know, say their names and just have them wave you. And then I will do a quick intro. I'll do a broader introduction when it's their turn. So we have Monica Nyirenda Mutesa. We have Martha Kamanga. We have Allen Namagembe. And we have Malvan Munjoma. And so these presenters will be able to speak about their different, you know, areas and and how they have been able to support women around rolling out self-administered methods. And so without further ado, let me introduce Monica Nyirenda Mutesa. Monica Mutesa is the DMPASC Access Collaborative Reproductive Health Director in the PATH Zambia country office, and she's also the country coordinator for the DMPASC Access Collaborative Project. She's a passionate advocate on women and girls' reproductive health rights. And today, Monica will be presenting on scaling up DMPASC and self-injection, Zambia's catalyst to contraceptive access. Welcome, Monica.
Thank you. Thank you so much for your kind introduction. I'll be presenting on scale-up of DMPASC and self-injection. I'd like to thank my co-authors, Tandiwe Sibulinjase from the Path Zambia office, as well as Julie Heinsen, who's also on the DMPA-SC Access Collaborative. So in terms of Zambia's family planning commitments made at the London Summit in 2012, Zambia set ambitious FP goals in 2012. One of its commitments included scaling up access to rights-based family planning through improving the method mix and strengthening task shifting to community-based volunteers to improve availability in hard-to-reach communities. This aimed to increase the MCPR among women from 33 to 58%. So the DMPA-SC Scale-Up Plan in Zambia included innovation. To achieve the FP commitments would require innovative approaches, which the Ministry of Health outlined in its 2013 Comprehensive Family Planning Scale-Up Plan. The plan named DMPA-SC as a high-impact intervention that could expand the country's overall method mix and promote rights-based family planning. The ministry directed injection-experienced public health care providers to begin administering DMPA-SC with a memo and job aid in 2018, which was really unique. So with funding from CHAI through the Catalytic Opportunity Fund and technical support from the DMPA-SC Access Collaborative, which is funded by Bill and Melinda Gates Foundation and CIF, PATH supported the ministry to expedite testing. This approach provided lessons learned for other countries that would seek to expedite self-injection and subcut training in less time and at lower cost, without sacrificing quality of care and counseling. PATH capitalized on the opportunity to include a rapid evaluation of provider competency and quality. We used a memo and a job aid to roll out the scale-up in Zambia. So in terms of jump-starting the sustainable rollout of SI at health facilities, we focused on 7 provinces. And if you look at the map, there were 7 provinces out of the 10 total that we have in Zambia. And so what the project did and the country office did was to use the innovative approach of leveraging supervision visits to provide on-the-job training for SI. And we trained provincial officials and district officials to actually provide this on-the-job training during their supervision and mentoring visits. So after supervision in the morning, they would proceed to, begin the on-the-job training in the afternoons, and they would maybe conduct it for about 1 to 9 hours, depending on, the traffic at the facility and so on. But on average, it was taking about 3 hours. So the tools that were used were training video, job aids, as well as client journey maps. So in terms of knowledge assessment, most providers scored 73% or greater. If you notice, there's a segment there where we have other cadres. So you have the midwives, the nurses, the clinical officers, environmental health technicians. The other cadre were the ones that are, like community health workers that come to the clinic to assist with work, or other daily employees that could be involved in the provision of family planning. So overall, it was at 74%, which sort of gave us the indication that actually we had adequate foundation of family planning counseling knowledge to support short method-specific training that would integrate key family planning concepts without requiring a full refresher training on family planning, and particularly emphasizing counseling. So the tool that was used for this was the Family Planning Basic Knowledge Assessment tool. So in terms of the initial stage, where before the on-the-job training was kicked off, we conducted an assessment for the 4 critical steps that required to administer DMPASC. So 31% of the providers satisfactorily completed the 4 critical steps to administer DMPASC. And this was done in order for us to assess as well what the gaps were, in order for us, when we are actually training them, which areas to emphasize and which areas they sort of needed capacity building, even as we conducted the training, and reinforce that. So with that said, I had already mentioned that we had said that the job aid and the memo were used. It also gave an indication that at this point, some of the healthcare providers were actually able to conduct this even without being trained, but just using the job aid and the memo. So the post tests were consistent across all the cadres. Of course, there was the lowest performing were the environmental health technicians, who performed at the lowest. These are a cadre that are trained to go and work in the communities. And in terms of the 4 critical steps, we observed that there was a great increase in the number of cadre that were able to answer correctly and do the actual 4 critical steps. And this goes to show that supervision is very, very key. Supervision and mentoring is very, very key, because with the job memo, with the job aid and the memo, it was at 31%. But after the supervision, the mentoring, we realized that this was an important component in order for us to scale up quickly. So in terms of the provider and trainer surveys that we conducted, it was indicated that providers were mostly or competently prepared to train clients. And the provider survey question was based on today's training: how prepared do you feel? And so the providers answered this question, and 72% of them said completely prepared, 25% said mostly prepared, and 4% said somewhat prepared. In terms of the actual trainers, the survey question was: do you feel the providers are ready to properly train clients who want to self-inject on DMPASC? The trainers were at 48%, said completely prepared, 50% said mostly prepared, and only 2% said somewhat prepared. So for those who responded on somewhat prepared, the 4%, some of the issues they raised was they needed more practice, or reviewing the training and the actual training materials. And some of the topics they wanted emphasized were client eligibility, the documentation process, counseling, and so forth. In terms of suggestions on how it could better be done, they spoke about making sure that there was advance appointments made with the clinics in order for them to be available, as well as consistent supply of the commodity, which is DMPASC, and to train more staff. So the key findings: the issuance of a memo and job aid alone was not sufficient to ensure provider competency in administering DMPASC. OJT is feasible for DMPASC scale-up when tacked onto regular supervision. It is a lower cost than classroom-based training, of course. And then majority of provider and trainer surveys indicate OJT was more effective than other training formats. Then collaboration from the Ministry of Health and partners is very key. And to emphasize, the leadership of the ministry is also very, very key. So pairing supervision mentoring with the on-job training proved to be an efficient way to improve the quality of provider-administered SC and rollout of self-injection. So in terms of the achievements for the Catalytic Opportunity Fund, we were able to train 1,790 providers in self-injection in the public sector in 7 provinces, in 625 health facilities. And then currently, the on-the-job training has continued, and we've continued using that method. We have 3,522 healthcare providers trained in self-injection, including 3,317 in the public sector, 139 in the private sector, and we have scaled up to 9 provinces. So in conclusion, like I mentioned earlier, a job aid can be a viable replacement for formal training among injection experienced providers when coupled with follow-up supervision to reinforce knowledge and competencies. It is as easy or easier to learn new skills through OJT compared to other formats, and OJT can reduce cost and time. When a country has a strong and reliable supportive supervision structure, OJT tacked on to regular supervision visits can be a sustainable, lower cost approach to rapidly roll out training to providers. I thank you.
Thank you very much, Monica, for taking us through Zambia's experience. We'll probably open up for one question if there's a clarifying question, but we will have like a broader Q&A. So just in case there's any clarification to the presenter while the presentation is fresh, happy to take that. If not, we can move on to our second presenter. Second presenter is Martha Kamanga. Martha is the PI, the co-principal investigator for Innovations for Choice and Autonomy, which is ICAN, in Malawi, and that's based at Malawi University of Science and Technology. She's a senior lecturer and the head of the midwifery department at Kamuzu University of Health Sciences. And today, Martha will be sharing a presentation on promoting self-care approaches through the use of DMPA-SC in Malawi. Welcome, Martha.
Good morning. Good morning. I'm Martha from Malawi, and as you've rightly heard, I'll be presenting on promoting self-care approaches through the use of DMPA-SC in Malawi. Our project is on innovations for choice and autonomy, ICAN, and those are the partners for this, like Akina Plus Health, Nigeria, Makerere University, Uganda, Kenya Medical Research Institute, and we have Malawi University of Science and Technology, Malawi, where I come from, and also University of California, San Francisco. In Malawi, we work hand in hand with the Ministry of Health, Reproductive Health Directorate. And our project is sponsored by the Bill and Melinda Gates Foundation. So self-care interventions, if situated in an environment that is safe and supportive, constitute an opportunity to help increase women's active participation in their own health. In this case, we are talking of DMPA-SC as a self-care intervention. In our country, Malawi, we have community HSAs who are a cadre of those people who have completed high school. And these are trained as community health surveillance assistants. Those are the ones I'm referring to as community HSAs. And we are saying these community HSAs may have the potential to address social barriers that inhibit DMPA-SC uptake. The question we're trying to answer was, what is the potential of community HSAs to promote self-care interventions, such as self-injectable DMPA-SC? So we did a qualitative study. In-depth interviews were conducted in 2 districts, Mulanje and Nchisi district. These are in 2 different geographical locations, and the women live in hard-to-reach areas. 60 women were purposefully sampled based on their age. So we had like age groups, 15 to 19 and 20 to 45 years, basically within the reproductive age group. They were also sampled based on their prior contraceptive use, that's use or non-use. They were also sampled based on previous experience with DMPASC. Interviews were designed to explore 4 domains. The first domain was contraceptive decision-making, then contraceptive use, self-injection, and also the 4th domain was women's experiences and preferences related to interacting with health surveillance assistants for contraceptive care. So my presentation today is based on the 4th domain, which is women's experiences and preferences related to interacting with the health surveillance assistants for contraceptive care. And I said these people have maybe a 2 weeks training in family planning, and then they also have a component of training 2 to 4 days in DMPASC. So wanted basically to understand how they can help to promote self-care interventions in Malawi. Data was transcribed and coded using Deduce software to organize codes and develop relevant themes. To understand the behaviors, we use the COM-BIS system, which is a framework for understanding behavior. As you might see in the picture, capability and opportunity is influencing motivation of the HSA, and this is influencing the behavior of the women who are the recipients of care. That's the self-care aspect. But also you might see that from the self-care aspect, there are arrows that are pointing to both, which means they are influencing each other. It can be in both directions. So in this case, we are saying maybe if the HSA provide impact knowledge to the women, if the HSAs are capable enough to impact knowledge to the women, that might influence the behavior. If the women consider the presence of HSAs as an opportunity, then that will help out to impact on the accessibility to HSA. And we are saying if we have motivated HSAs who are able to deliver according to the expected standards, then that will help to promote accessibility of HSA. And all these capability, motivation, opportunity will lead to women making a proper decision for DMPASC. So my focus is on this. We use these concepts: capability, motivation, existing opportunity within the community. That's the HSA's potential will be based on whether the HSA is capable. That's the first one, capability. Existing opportunity within the community, and if the HSA is motivated enough, will be able to change the behaviors of the women. On community HSA's capability. So our findings revealed that community HSAs have the capability to impact knowledge. So they have the appropriate knowledge and abilities required to share information with women as well as adolescents. For example, one of the participants narrated, "I'm very comfortable with our community HSA because he gives us information about contraceptive methods, which helps us in our family when we follow all the information that he gives us. There is privacy when talking with the HSA. We talk at a place where there are 2 people or few people around, and so we get comfortable talking about contraception methods. So we see that the women are comfortable with this HSA. Maybe they are comparing with the facility situation where people are overcrowded, or sometimes they complain about the provider behaviors. Also, another participant says there was a paper-like calendar, and on that there were different family planning models like Loop. There was also a natural method of family planning, and there were also other modern family planning methods, which means the HSA was capable enough to use the teaching aid, and then the women were comfortable to follow. So the HSA proved to be capable to help the women understand the family planning methods. Looking at that's the second one. The first one was capability. The second one is opportunity. Looking at the opportunity, so community HSAs act as an opportunity for the women to reach out to them at any time. So the community HSAs are situated like they are in the communities. And the women were testifying to say, we have a provider, in this case an HSA, in our community. Every community has an HSA. There is a hall which was constructed by Gaia in Group Village. That's what we use as our clinic. The provider explained to us about Sayana before it got here. So it's an opportunity to have the HSA within the community, and women can access the DMPASC at any time that they want. And they are testifying to say he's the only one who lives close to us, so it's very easy to communicate with him. We can't move from our community to get services from another HSA in other location. So they feel comfortable with their own provider, and this is an opportunity for us to use to increase access to DMPASC. However, there was also those who didn't have the HSA within the community. There was an appeal. They said the only support that I will need is that the community HSA should also be supplied with this injection method that we inject ourselves. The reason is, someday it can happen that you are very occupied, either you are far or you have forgotten that you were supposed to go to the hospital to get family planning method. And you are just remembering in the evening around past 5. And by that time, they have already closed the hospital. You can just go to the community HSA, even during the night, like past 8. This means that they can give you, and you'll be able to inject yourself without any problems. They are emphasizing the women to say, you know, we need these people, community HSAs, because sometimes we have other things as individuals. We can't afford to be going to the clinics. So we need them in the community. So that is an opportunity for us to use to increase access to DMPASC. The third aspect was on motivation. So our results also showed that HSAs are motivated and inspire women to self-inject. They say community HSAs offer privacy when sharing information to women, hence command the necessary trust from the women. When we go to meet the HSA, they take us at a private place so that other people should not know why we went there. They greet you nicely and ask you the reason for the visit. So you tell them your reasons. If you want to get family planning, you tell them, and they teach you about family planning before giving you. They teach you how to use the family planning method. Then they give it to you, and they will tell you when the drug will finish, and they also tell you you have to go again to get the drug when it finishes. So they are satisfied and they are motivated to continue. Similarly, how the HSAs motivate women and inspire them. The women are expressing, I should thank our HSA and those who send this family planning method to us, because they have reduced our work. We no longer have to walk a long distance to get family planning, because they now give us the method to keep in our homes. That's the good thing that I see with this method. It's still testifying to the fact that the women now are inspired to continue using the method that they get from the HSA. And they're saying the community HSA, we call them doctors to make them feel good. They feel so good. Yeah? They are the ones who provide contraceptives in our villages, and also we stay nearby, still showing us that they take them as important people with them. It is good because I don't have to go to the hospital to get an injection, where there are a lot of people who can take note of you. So what are we learning from this? Community HSAs may provide aspects of knowledge, motivation, and opportunity that may act to support women's selection of DMPSC. Community HSAs might provide a means to encourage behavior change, to scale up access of DMPSC within the community by bringing information, by bringing services, by bringing supplies to the women, rather than requiring them to visit healthy facilities which may be distant or otherwise inaccessible. So, what does this mean? Expanding DMPSC services to community HSAs might be a feasible way to increase access to women in need of the service. As I said, those are the items. I can, like the consortium, and we also acknowledge to our participants, we acknowledge to the Ministry of Health, and we also acknowledge Bill and Melinda Gates Foundation for their continued support and guidance. Otherwise, thank you.
So thank you very much, Martha. Thank you for sharing the experience from Malawi, as well as bringing in the voices of users into this conversation. And so our next presenter is Allen Namagembe, who is a clinical epidemiologist and biostatistician with over 10 years of experience in research, monitoring, evaluation, data management, and policy advocacy. She's currently working as the Deputy Project Director and M&E lead on the Uganda DMPASC self-injection scale-up project with PATH in Uganda. And Allen also serves as a global and regional expert and resource on self-injection and a member of the Uganda Self-Care Expert Group. And so this afternoon, Allen will speak to us on contraceptive self-injection through routine service delivery, the experiences of Ugandan women in the public health system. Welcome, Allen.
Thank you so much, Patricia, for the kind introduction. Good afternoon, everyone. Yes. I'm going to speak about experiences of Ugandan women in our public health sector on DMPSC self-injection. I want to start by acknowledging my co-authors, Jane Kova, who is in the room, Chloe, Justine Tumusime, Damalin Sanji, and Jane Drake. So we designed a Uganda self-injection best practices project to help us understand how a contraceptive self-injection program could be designed and implemented at scale through different delivery channels and under real-world conditions. We looked at the facility-based program, community-based program, and an adolescent program where we reached adolescents through clinics and through their safe spaces. We evaluated the program to assess the extent to which women in the program were successful with self-injection, the nature and quality of the training they received, the level of satisfaction from the clients, their experiences with post-training, follow-up, and independent self-injection at home, waste disposal practices and resupply experiences, continuation with self-injection, and reasons for discontinuing self-injection. As we start, this is kind of a data flow after 1 year of collecting routine monitoring data. There were over 7,000 self-injecting clients over the 1 year period, and most of these clients took 2 units of DMPSC home with them for independent self-injection, and 1,400 returned for resupply. To really measure successful self-injection, as Monica said, we assess the 4 critical steps, and these include mixing the drug, activating the device by breaking the seal, pinching the skin to make a tent to ensure that the injection is given subcutaneously, and squeezing the reservoir slowly so we don't have any drug coming out. Next, I want to talk about the competence, and this was similar across provider and training location. We can see the blue are the VHT, the community health worker clients, trained clients. Then we have the clinic-based clients. Then the adolescents were trained at safe spaces. And these safe spaces would be schools, churches, where the Dreams Approach programs were happening. Then we also have adolescents who are trained at the facility, and that will be local, usually Mubende. When I refer to Mubende, that was the districts that implemented the adolescent program. So in the public sector, competences were not significantly different for clients trained at the clinics and clients trained by the community health workers. And in the adolescent program, participants at the safe spaces demonstrated higher competence than those trained at the clinics. And activation of the device was the most challenging step to do. We also wanted to look at competence across age groups and districts. And competence varied little by age, but it differed considerably by districts. As you can see, Gulu, Mayuge, and Oyam were all public sector implementing districts, and then Mubende was the adolescent channel implementing district. One of the issues that we had really found out in area research from the providers, they found training of self-injecting clients time-consuming. So we wanted to find out some ways of cutting down on that time and lessening the burden. So we had trainings, both group trainings and one-on-one. Group trainings really to help us cut down on time, but we wanted to really assess its effectiveness. And clients trained in a group demonstrated good competence relative to clients trained one-on-one. A combination of group and one-on-one worked best. However, this approach was uncommon. And one-on-one training was more common among community health workers, as we would expect, because clients don't communicate to each other to visit, compared to the public health facilities. They conducted more of the group trainings. We also wanted to look at the timing of the training and how its effect on effectiveness or on client competence. Women whose training was very brief, that is less than 20 minutes, were less able to demonstrate competence. Even as we want to really lessen the time, we don't want to compromise the quality of training. So we have to strike a balance between the two. And women whose training did not cover all the self-injection topics were less able to demonstrate competence. The other factor that contributed to competence was the use of the job aid. And this is a one-pager with a lot of pictorial illustration to take into consideration also the less literate women. About 3/4 of those receiving training with a job aid during demonstration demonstrated competence, compared with about 1/2 of those who did not receive a job aid. and women provided with job aid to take home were significantly better able to demonstrate competence than those who did not receive a job aid for reference during the independent self-injection. We followed up women after they should have re-injected at home with the units they took home to find out if they did it, and if they did it correctly, if they discontinued, what were the reasons for discontinuation, and their disposal practices. Regarding re-injection, most women who did so on schedule, and that is as per the WHO recommendation, 2 weeks earlier or up to 4 weeks after their rescheduled re-injection date. Although you can see that in the adolescent channel, the percentage was less, but when we tried to look at adolescents in the public sector, they were just as likely to re-injection time as older women. And as we can recall earlier, even for competence, the adolescent channel had slightly less competence levels. Some of the factors that contributed to re-injecting on time were training women on a calendar and giving them home with for independent self-injection. And in this slide, we can see that on-time re-injection is more likely if women are provided with a calendar to doing the training and to take home for independent self-injection. Looking at the discontinuation, wanting to discontinue the method was the common reason for non-self-injecting. We see that a small share of women in the public sector at 6% had not self-injected, and 20% had not re-injected in the adolescent channel. A sizable share of those in the public sector who had not self-injected offer a reason suggesting they need more support with self-injection. Reasons like they tried and failed to do it, they felt fearful to inject themselves, or wanted more training. And many women in the adolescent channel said they did not want to continue using DMPAC as an FP method. Looking at waste disposal, protocol was they were told to put the used devices in a puncture-proof container with a cover and return it to either a community health worker or a facility-based provider at their convenience. So clients were provided with this container, and 93% in the public sector and 87% in the adolescent channel placed the used device in that container before disposal as guided during the training. 73% in the public sector and 67% in the adolescent channel still had the device at home during the interview, as expected, because they were not, we didn't require them to move back to the facility or to a provider just to return that. But we expected if they kept it in a container, then they would do that at their earliest convenience. So to speak about acceptance of the program, 96% of the public sector clients and 87% of the clients in the adolescent channel said they would like to continue with self-injection if it were available. Remember, this was at a point when we wanted to learn more about the program to inform scale-up. And this, largely the results from this evaluation and some other research studies informed our scale-up guidance in Uganda. So recommendation, as I conclude, to maximize women's ability to master self-injection Providers should offer clients a comprehensive training and confirm proficiency, focusing on mastery of the 4 critical steps before clients are given units to take home. In particular, emphasizing how to activate the device, because that is the most challenging step. Training clients using a job aid to guide them on how to interpret it, and giving them a copy to take home for independent self-injection really improves their competence in how to do self-injection. As we learned from Martha, the Malawi study, community health workers play a vital role, not only in raising awareness of self-injection, but also in training clients on how to use, on how to self-inject. And we saw their clients from that channel performing, as well as clients trained at the facilities. Also, group training is feasible with appropriate group size. We recommend capping this to 10 as an option in busy clinic settings, but we should ensure that there is a chance for one-on-one interaction as needed, because some women might have a few questions or some need for clarification one-on-one. Thank you so much.
Yes, so thank you, Alan. Thank you for sharing Uganda's experience. In case there's any clarification question to Alan or to Martha, please do share. But I guess if not, oh, okay, just a clarifying question, but we will have an, yeah, go ahead.
I'm from India, and we are going to start the DMPA SC. So my question is to Martha, that you talk about the HSA. So these HSA are volunteers, male or female, or what the qualification, how they are going to be selected to become a HSA? Because we have a structure of ASHA worker. She is female and she is like a completed middle school. So, yeah, please.
Thank you for that. I'm lucky I have the program officer for the reproductive directorate who deals directly with the HSAs in Malawi. I would like to call her to help my friend on the, sorry, I would have mentioned your name, but I would like to call Jessie to clarify on the procedures for the HSAs. I briefly said they are the ones who have completed high school, Form 4, but Jessie should clarify more on the training. Thank you.
Thank you so much. I'm Jessie Salamba Chirwa from Malawi. I'm the DMPA AC focal person. And in Malawi, we had already rolled out nationally for both provider administered and self-injection. Now, coming to the HSA, these are community health workers that have been employed by Minister of Health. And the Minister of Health employs those that have attained a higher level of, we call it MSc, from finishing the high school. And then when they are employed, they are oriented on health services that they have been employed for. So it's not only family planning, they are oriented, they are trained on vaccination or immunization, child health, monitoring of growth and nutrition, and also on disease surveillance, where they will be going into the communities and do disease surveillance. And on the community-based part of family planning, we deliberately, as ministry, use them because they reside in the communities where women and other clients, adolescents, they can easily reach them. So maybe that clarifies your question. Thank you so much.
Yeah, thank you so much for that clarification. And so our last presenter is on health system strengthening and improving efficient indicator monitoring. So today, Malvan will be sharing with us work on DMPSC from Zimbabwe, and his presentation is titled Women Can Competently Self-Inject DMPSC, Evidence from a Low-Resource Setting. Thank you, Malvan, and welcome.
All right. Thank you for the introductions, and good afternoon, everyone. So we are also here to share evidence from Zimbabwe, just to ice break with some bit of context in terms of our population size. We are around 15 million, and about 23% the 15 to 49-year-old age band, reproductive age bands. Our crude birth rate, as of the latest estimates, are around 28.7 per 1,000, with a total fertility rate of about 3.9 children, women. So we see a higher fertility rate in the rural population compared to the urban setting. And also just to give a bit of highlight in terms of unmet need across different geographies, we have thought of sharing the Zimbabwean map and the heat map for unmet need, which on average is around 10% as of the latest ZDHS. And we do have evidence to show that young women, they still face significant barriers in accessing modern contraception. And we have a national reproductive health strategy to try and reduce that gap of teenage pregnancies from 24% to below 10%. But as you can see from the heat map on unmet need, we still have some provinces that still have quite high unmet need. I'll pick, for instance, Matabeleland in South with about 16% and Masvingo with 15%. So the drive to offer more contraceptive methods is apparent, and it's there, and it's part of the national agenda for the country. And we believe that self-injection methods do really offer that option as we continue to reach more women. So I won't spend much time talking about the DMPASC. I think the previous presenters did mention what DMPASC is. But we do know that this is definitely a potential game changer in increasing access to, contraception in low to middle income countries. So Population Solutions for Health, PSH, with funding from the Embassy of Sweden, conducted a feasibility study to support scale up of this method in the country. So broadly, our objectives looked at basically looking at the feasibility of DMPA-AC self-injection among women of reproductive age, addressing the following specific objectives. Number one, we wanted to develop a user-friendly manual that can be scaled up and used by women as they self-inject. And this would be adopted from the manufacturer and then customized to the local context and also translated into vernacular languages for ease of use. We also wanted to measure the proportion of clients who would competently self-inject, and also measure proportion of clients who would self-inject on time, defined as within 7 days of the scheduled re-injection date, and also measure competency rates at 3 months, at 6 months, and at 9 months. And lastly, just to also get a sense of the users and providers' perceptions on ease of use of the actual method to inform scaling up. So this was our methodology. We took a prospective cohort study approach, following up women, recruiting them at baseline, and then following them up at 3 months, at 6 months, and 9 months. And our study data collection period started around May of 2021 up to April of 2022. And our study population was 15 to 49-year-olds with 11 study locations. We had 4 public sector facilities and 7 NGO funded facilities, which also offered some integrated HIV and SRH services at those sites. We included sexually active women with no pregnancy intention for at least 9 months for enrollment to date, so that we can at least protect our continuation rates. And also our study outcome was mainly self-injection competency, but we also had other secondary outcomes that you saw earlier on. Those were the parameters that we used to calculate our sample size. Our minimum sample size required was around 683, and we distributed this sample size across the 11 sites using probability proportional to size, according to women who were accessing the DMPA intramuscular version of that method. And then we would follow up clients, like I mentioned, at 3 and 6 and 9 months. And competently self-injecting women would receive doses to self-inject in the subsequent follow-up periods. We measured self-injection competency using the 17 list checklist. I think my previous presenters also mentioned that competence was measured using that 4-step checklist, the critical steps of the 17 checklists that would normally come with the manual. So the study was approved by the local IRB, the Medical Research Council of Zimbabwe, for ethical approval. So moving to the results, our demographic characteristics mostly resonating with the total population size. About 79% of our respondents had learned up to secondary level. And one of the big findings that we saw was high acceptability among the adolescent girls and young women. You can see the 15 to 24-year-old age band had more than 50% of the sample that was accepting DMPA. The other demographics on marital status, 46% were married, mostly were predominantly Christian, and most were also, the highest proportion came from women that were self-employed, which also resonates with the current employment status in Zimbabwe. And age at contraception debut, you can see the graph is peaking. The modal age was around 19 to 20, was actually 18 years for age at contraception debut. Profiling the clients by previous method used, we saw that most had been using COC or POP condoms, and then about 15% were using the intramuscular version, and about 8% were new users of family planning. So again, we see the opportunity that DMPA-AC is bringing in terms of expanding our contraceptive preference. We had about 8% new users. So this is a snippet of the user-friendly manual that we developed. It was translated in vernacular after some iterative cognitive interviews with clients, so that we make it as easy as possible to follow. And we also worked with clinicians and service providers to translate the language so that it becomes very easy in terms of the language that one would understand. We try to make it as easy as possible for any sort of demographic profile so that they can understand how to use it with relative ease. So this table is now showing us some of the key outcomes of our study, starting with self-injection competency. That was 77% at baseline, increased significantly to 89.6% at 3-month follow-up, and again higher to 95.2%, and at 9 months, 97%. So we can see self-injection competence increasing proportionally and directly with time, and it was significant. We also checked for any significant differences by different demographics, and we did not see any, perhaps speaking to the fact that our user manual was actually quite friendly, because we had women of different education background, we had different geographies and different age groups, and they all managed to self-inject uniformly. Our continuation rates at 3 months, so our method continuation, we were measuring them among women that we could follow up at each successive stage. to see if they still or were willing to continue on the method or not. So to see at 3 months, it was 58%, but among women that we did follow up at 6 months, 78% were continuing, and at 9 months, almost 80% said they would want to continue and were continuing on the method. Timely self-injection was also quite pretty high. We see 80.8% at 3 months, 87% at 6 months, and 92% at 9 months. One limitation that I would mention is we didn't manage to follow up all the clients that we could have at 9 months because our study period was a bit short. But so our 9 months follow-ups were not done completely. But of those that we did manage to follow up, 92% did self-inject on time. Then we look at the client's perception on ease of use. You can see generally that majority of the clients did report that self-injection was relatively easy. We did, however, found at 3 months about 5% of the clients reporting facing challenges. Some were fearing a self-injection. I think this is resonating with previous speakers, and also forgetting to follow up steps ahead in the case of losing the manual that we had given to the women. We also profiled by age the subset of clients that did discontinue. And we saw high continuations for the youngest age band, 15 to 19, and the oldest age band, 40 plus, of about mean weeks of about 19 and 18. And then the middle ages had lower continuation rates, perhaps speaking to the need to get pregnant maybe in the 20 to 34 age band. We understand this is the highest reproductive age, so to speak, of women more willing to have children, or also mobility by virtue of their careers. And also we know that the youngest and the oldest tend to be not as mobile as the other age band, and moving to other areas where the method is not yet available. So reasons for discontinuation, we see the highest proportion had relocated to where the method was unavailable. Some reported bleeding, 34%. 12% decided that they wanted to now have a baby, and other side effects were also reported. Contraceptive method use and discontinuation. We say the method that they chose after they discontinued, most were no longer using a method, and the second most reason given was COCs and POP. We also took time to get service provider perceptions. I can read one quote there that's saying there's been a lot of negative feedback from the DMP-IM side effects. We hope that the subcat version press has less side effects compared to IM due to its lower dosage. But that convenience of decongesting the site was also mentioned because clients will have a chance to self-inject away from the facility. So in summary, these are the key findings. I may not want to repeat them because I did mention some of them, but the first one, you can see about 7%. We see there were new users. Self-injection competence was overly high. Method continuation was also fairly high, increasing over time, and our service providers did report reduced client volumes at the facility. So our findings, good to have Ms. Culver in the room. We did learn a lot from the previous work that the team did in informing this study. We acknowledge that, and some of our findings do resonate with the findings that we are seeing from the work that they did. So in conclusion, what are we saying? We're saying DMP-SC self-injection is acceptable and is feasible. With more than half, about 57% of the clients accepting DMPA were actually the adolescent girls and young women. Women receiving DMPA managed to achieve high self-injection competency, and we didn't see any disparities by any covariate in terms of lack of competency. There is this perceived benefit that we are seeing reported by service providers in decongesting the health delivery points due to DMPA self-injection. And I'll conclude by looking at the recommendations. We are recommending scaling up of DMP-SC family planning method to the private and public sectors and health facilities to increase our method contraceptive choice. And the developed user custom self-injection manual should actually be used and considered as we scale up the intervention, as it did demonstrate that if we come up with a user-friendly manual, self-injection competency can result. I would lastly conclude by acknowledging the Ministry of Health and Childcare, the National AIDS Council, the Zimbabwe National Family Planning Council, the Swedish Embassy who funded this activity, PSI, and of course, lastly, the study participants that made this work possible. I thank you.
Thank you, Malvan. And so we've had 4 different presentations from 4 different countries. Starting with Monica, who took us through, Zambia, scaling this DMPSC self-injection through a modality of on-job training with during support supervision visits. Then went over to Malawi, where Martha talked about the perspectives of clients who had, who had interacted with community health surveillance assistants. Who was supporting them to take up DMPSC, self-injected. And then Alan then shared with us, the best practices project in Uganda to understand, how do you optimize self-injection? What exactly would you need to have in place for this to be scaled up? And then Malvan has just spoken to us about a study in Zimbabwe to assess the feasibility and some of the recommendations they have as Zimbabwe considers scaling this up. And so now it is your opportunity to interact with the presenters and opening this up for a period of questions and answers. So we'll take about maybe 3 to 4 questions. Hopefully we'll have an opportunity for about 2 rounds of questions to the presenters. So welcome. Step up to the mics. I think there's a couple of mics in the room. And if your question is addressed to a specific presenter, please do say so. But otherwise, presenters, just note the questions. And oh yes, feel free to introduce yourself and perhaps what organization you're from as well. Thank you.
I'll speak louder. My name is Dan Hartman. I work for the Global Litigate Foundation, and thank you to all the presenters. I was curious on the first presentation what the definition of success was, because it seems like 70% success doesn't seem that high, because the method's highly effective, but if it's only being used 70% correctly, then that wouldn't be a highly effective method. And then I was also struck by the difference in the sizes of the studies. So there was almost a 10x difference in the size between 60 to over 7,000, and how you decide on what the size of your implementation studies would be. Thank you.
Hi, Kelsey Holt from UCSF. I also had a question for the presenter from Zambia. You mentioned the use of journey maps as part of the on-the-job training, which caught my attention. I wonder if you could share more about that, please.
Great. Yes, welcome. We'll take one more question in this round, and then, or even 2 more, and then we can.
I want to know that some presenter mentioned about the discontinuation is a reason of discontinuation. So I would like to know that what is the plan, like the women who are facing some side effects. So what is the side effect management or the discontinuation management plan? How they are reaching again to the women who have discontinued due to the side effect or some other reasons. So what's the plan here?
Okay, so one last question, and then, yeah.
Thank you all presenters. Fiona from Uganda. This goes to Zimbabwe. How many was the first injection given before a health provider? the first injection to the client, was it observed by a healthy provider? And also to ask how many units were given the women to take home.
Great, some great questions. So I think we can start from Alan coming this way. So if there's any question to you, feel free, and then we'll just move all the way to Malvern.
Thank you. I think my question was on the plan for management of side effects for self-injection, given that it was one of the commonest reasons for discontinuation. So one of the recommendations is to do comprehensive counseling, which includes a possible information on possible side effects and how to manage them. And then even when women are given units to take home for independent self-injection, they're encouraged. If they encounter side effects, given the magnitude or what side effect they are encountering, to return to the provider for support and management. So then it's not like we are detaching them off the healthcare system. Actually, the healthcare system is there to support them through their self-care journey, but they can do it with or without the healthcare system if that is possible or needed. Over.
Okay, and then I think just Dan's question, what determined the size of your study, the size of the study?
Oh, the size, because as we were doing routine service delivery, we got women from the register. So it was those who received self-injection services within a 1-year period of time. And that is really it. Over. That's it for me.
Yes. Thank you. Yeah, next presenter.
Thank you everyone for the question.
Thank you so much for those questions. I am supposed to answer around the 76%, right? Just to give clarity on what we were talking about. We're speaking to the 4 critical steps, the examination or the test on how well the providers were able to include all the 4 critical steps. So for example, if you only included 3, you were not counted as having completed. So initially, before we did the on-the-job training, 31% were able to go through all the 4 critical steps using the method of just getting a memo and a job aid. But after the on-the-job training, that's when the score rose to 76%. So from that perspective, we thought we had a success. But overall, in terms of success, we were looking at actually the numbers that we have trained to be able to train women to self-inject in all the 9 provinces, as well as the numbers that include actual private pharmacies to train women to self-inject, amongst some of the successes we have had. Does that answer your question, sir?
I think perhaps maybe the question is, what's the normative? Like, if it's is 76% of your clients successfully being able to administer, is that a low bar? Is that, and I think that's perhaps really the heart of the question.
Okay, so it's more the providers. We didn't deal with the clients. We dealt with the providers being able to actually train the women. So this 76% post-test was the providers and how they were able to include all the 4 critical steps in their training when they train the women. Yeah. But for the women, they have to, they have to have the 4 critical steps before they can. Thank you.
Yeah, I can start with the sample size question. I also see that the 3-4 different studies that were presented here today, one was qualitative, another involved primary data collection, and the other one, like she mentioned, was program data. So ideally, yes, the sample size would have that range. But also, I think I've seen for studies that are comparable that involved quantitative primary data collection, the sample sizes, I think, from literature ranged between 300 and 800. From what I've seen in literature regarding DMPA-AC. So they're quite comparable, and yeah. Then on side effects management, I know our routine program SOP is that if a client reports side effects, say for example bleeding, we made sure that at every follow-up visit, or if they report to the site, they would get proper counseling from the clinician regarding their way forward. Number one, they would assess the severity of the side effects, if it's an adverse event or if it's something that is normal or manageable with another secondary, dispensing or recommendation to take to try and counter that, or better off be recommended to take another different method that has less side effects. So essentially that's the SOP that this study followed in terms of side effects management. And then on the question on first instance of self-injection, indeed the clinician observed and actually assisted all clients at first instance of trying to self-inject. This was observed, this was supervised by the clinician, and then if they demonstrate that they can competently do that, they would get one additional dose to inject at the place of their convenience. But because the study was also under protocol, we would still call them when we knew they're about to be due, and then we would go to the place of convenience so that we can continue with observations on self-injection. Thank you.
Great. I think we have time for a couple more questions. Yes, so feel free to step to the mic, introduce yourself briefly, and just keep the question super brief.
Okay, I've already introduced myself. My question goes to the third presenter. You talked about adolescent channels in Mubende saying that they had discontinued on the method. They didn't want to continue on DMPA-SC as an FP method. Why? The second one was there any uninformed consent at the start of the method? Were these adolescents ably informed on how DMPA-SC works and any other side effects that they may experience, and what are the advantages of using DMPA? Thank you.
Thank you.
Thank you, all the presenters. My name is Nyando. My question goes to Uganda. I observed that there was significant women living out the study, more or less going towards what the previous question was. I just want to find out the sample mix in terms of their level of understanding. How was it chosen in terms of levels of understanding? What was the sample mix? The other one is just maybe a general comment that to all the presenters. I think this is a good study to all in all the countries, because we're almost neighboring countries. Is there a point that we can share notes? And Malawi, there's Malawi, Zimbabwe, Uganda, Zambia. So these are countries within the region. Is there an opportunity where we can share notes and learn from each other where are the gaps and how we can improve? I think this presentation has opened an eye that we can share notes. That's what I wanted to say. I noticed that there was some differences as well in terms of but there's a clinic, a mobile clinic, and the other. So why were there these nuances in terms of the outcome of your uptake in the DMPACI? Thank you.
Okay, great. So I think we are out of time, so I'll ask the specific presenters to answer that question. But I did also want to ask one question to Monica around your experience in expanding this to the private sector, because I think you're the only presenter who included the private sector. And so maybe you could speak to that briefly, and then we'll wrap up.
Yeah, just to start with the discontinuation, thank you so much for those questions. Definitely, discontinuation, we wanted to explore why they were discontinuing, and they wanted to stop a method. We want to appreciate that DMPAC and self-injection is not for all women, and we are adding this to the method mix. So if someone wants to discontinue a particular method and maybe take on another that's acceptable, but also they could change. There could be a change of mind for their fertility intentions. Maybe they want to now have a child. So as long as it's informed, that's very okay. And for the issue of informed consenting when they're starting, we want to really use these opportunities when we're introducing a new method to reinforce and strengthen our family planning programs, like informed counseling for informed choice. So the training really covered a lot of informed choice counseling, not only for DMPAC, but for all family planning methods. And that said, this was within routine service delivery, so there would be variations on how providers really implement this. There wasn't very much standardization on how they do it like we would do in a clinic or any research setting. This was in real world conditions, and we wanted to learn that because we had seen very good results from the research, but our government was like, this is very controlled. How will it play out in the real world condition? And that is what we learned. But maybe just a clarification for service provision, it's routine counseling, then they are guided and they choose which method to take on. But for the evaluation for the adolescents, our IRB only allowed us to interact with emancipated minors for the adolescent and young girls, just so we take that. Level of understanding, we did not want to, this was routine data, so we would just randomly selected women who were receiving a service, irrespective of their level of education. But what we learned is there weren't any significant differences among women of different levels of understanding, hopefully, if we take it by education level. I think that's it. Thank you.
I think maybe the next question is to Monica, but we will give Martha towards the end. We'll give you a chance to say a last word. So.
Thank you very much. To your question around the client journey maps, the client journey maps give instruction on how the client will go through the process to get to the point where they will self-inject. So we normally have posters that are put up in the clinic that will show a provider the process through which the specific client should go through, what should happen at each point when they come in, what do you do, how do you train them, how do you like triangulate and all those processes. So that's what the client journey map is all about. Then with regard to the private sector, I should have said that that was one of the things we feel really proud about, because given the current situation where funding is being reduced for family planning commodities or services, it is important that the private sector begins to get involved. And the case of Zambia is something that our colleagues can learn from. We have trained 136 pharmacists to provide, to train women in self-injection and to actually provide DMPASC in the private sector. And this is happening. We've started up in 4 provinces, and we're hoping to scale up to the entire nation. I think it has been a very good partnership with other key stakeholders in the country. The ministry has taken a lead. The private pharmacies association is also part of this to ensure that we meet the standards, but also it was about ensuring that policy is in place that this could happen. So we are monitoring this very closely. We have agreed there's a roadmap on how we are going to scale up to the entire country. So yeah, it's something that we're very excited about. Thank you.
Great. So in view of time, perhaps 30 seconds for everyone to just tell us, what call to action would you have for our audience based on your work? So we'll start with you, Malvan.
All right, thank you. I would say, DMPA SC self-injection is definitely a potential game changer. I think countries out there should adopt this new method. We should scale it up. It particularly resonates with new users as well, and also young women whom we know they face a lot of discrimination trying to access, family planning services at the health center. They look at you if you're a 15-year-old or a 16-year-old who's trying to get a service. So self-injection methods offer that avenue and that ability to empower the adolescent girl and young women to own up their reproductive choices and increase our contraceptive prevalence rate. So let's scale it up. Thanks.
Sorry. I was taking advantage of the of the opportunity to ask for call for action, so I was writing down so many things to say. But the first one that I would really appreciate is for us to begin to advocate for governments to begin to put funding into this kind of work, because I think it is very, very effective. And currently, in terms of sustainability, the donors are putting in so much. It's time that our own domestic governments were financing this kind of work. And so I would request for that. I know this is a very good method, and it would be good if government could put money where our mouths are. Thank you.
Okay, from Martha, thank you for this opportunity. Learning from our scenario, we have different experiences. Like in one area, more providers are trained, while in the other area, less providers are trained, and this impacts on the quality of the service for the providers to offer DMPA-SC. So my call for action is to train more providers so that they can reach out to the women who are in need of this service. And apart from the training, we need to support them, because it seems like the providers are just trained and they are not supported. So we need supportive supervision for the providers so that they assist our women ably. Maybe we might talk less about the issues of side effects, the issues of discontinuation, if we support our providers in this. Thank you.
Thank you. Given the agreement of results across geographies, I want to say self-injection is feasible, acceptable, and should be scaled up and mainstreamed in all service delivery channels for women who need it. Thank you.
Thank you, Alan. Short and sweet. And so I think just to wrap up with the question from our colleague from Malawi, I think there's the Access Collaborative Project, which is supported by PATH and JSI, that organizes webinars and does have learning and action networks, both an Anglophone and a Francophone. And hopefully, the teams here who are part of the Access Collaborative can see that there is a desire and energy around, sharing from multiple country experiences, whether it's in study settings, from routine service delivery, or using and optimizing different delivery channels. And thank you so much for your patience, our audience. Thank you to the presenters for the great presentations. And enjoy your lunch.